In today's webinar, we'll be reviewing some of the challenges that payers, health systems, and self-funded employers face when they look to expand or stratify the provider networks, followed by strategies to help address these challenges. We actually began planning the content for this presentation in January, and it will largely remain the same, but we feel it may be beneficial to view this information through the lens of current events as we are truly entering uncharted territory as a healthcare ecosystem. Organizations will be looking for ways to reduce unnecessary spending wherever possible, now more than ever, and that includes healthcare spending. On the surface, it may sound a bit crazy, but from a glass half full perspective, it presents a huge opportunity for payers and healthcare systems to step up and implement strategies to improve the cost efficiency of the provider networks, especially when expanding coverage into unfamiliar areas. Before diving into payer challenges, let's set the stage by taking a 30,000-foot view of some of the major problems plaguing the U.S. healthcare system. According to the Centers for Medicare and Medicaid Services, national healthcare spending was projected to reach $3.8 trillion in 2019 and will climb to $6 trillion over the next 7 years. As you can see from the chart on the left, we spend more on healthcare per capita than any other country, but we do not achieve outcomes proportionate to that spending. 30% of spending is estimated to be low-value care, meaning it does not follow medical best practices and is unnecessary, wasteful spending. A CT scan or an MRI for a patient with lower back pain, but who has no signs of a neurological problem, is one example. Beyond the heavy price that the public and private purchasers pay, low-value services often harm patients, such as the negative side effects experienced after taking medication that was not needed. Low-value services also lead to lost time and productivity, which has an entirely other financial impact of its own. Meanwhile, you'll see the results of the 2020 Large Employers Healthcare Strategy and Plan Design Survey on the right, showing that the average cost of healthcare coverage per employee will reach over $15,000 this year. With costs continuing to rise, eliminating as much low-value care delivery as possible is increasingly becoming a necessity for health plans and employers alike if they want to minimize spending. The concept of eliminating low-value care is one that most organizations can get behind. But how exactly is it done in practice, and how can your organization stay a step ahead during network expansion efforts? It all comes down to identifying which providers will deliver the best value and working to prioritize utilization of those providers. Keep in mind, a provider who delivers low-value care can still be extremely skilled and well-renowned in the medical community. But it does not mean he or she is providing care that is of high value, which ultimately will lead to cost increases for payers, employers, and for that matter, health systems. To achieve value, one must always balance cost and necessity. We're going to examine two spotlight cases and connect the overall goal of reducing low-value care to practical applications. Case number one involves a health plan that is set to increase market presence by expanding coverage into a brand new geography, while case number two examines a self-funded employer and their efforts to reduce healthcare costs through network stratification. For case number one, we are entering the network expansion process of Health Plan X at the beginning of implementation. At this point in time, the health plan has already conducted an extensive analysis of the new market they plan on entering and the requirements needed to stand up the new network. Barring any setbacks, they will be moving forward and begin contracting with providers to satisfy network requirements. So they now face a serious problem. Without historical information on the providers in that region and a method to effectively analyze those providers, they have no way to project cost efficiency from one provider to the next. They will essentially be flying blind and at risk of contracting with low-value providers who may cost them millions of dollars more than high-value alternatives. In the absence of information, the plan will assume some initial risk and instead set a goal of analyzing provider cost efficiency after enough time has passed. But by then, it may be too late. If a low-value provider is being utilized by a lot of plan members, he or she may be deemed untouchable for fear of potentially losing or alienating those plan members. The best solution is to contract with providers from the start who have proven to be high value over time and who project to be high value in the future. For case number 2, a self-funded employer is attempting to lower the cost of providing health care to their employees. They have certain fixed costs, such as administrative fees and stop-loss premiums, which are charged based on plan enrollment. But they also have variable costs to be wary of, such as the actual payment of healthcare claims that can vary dramatically from month to month. Just like payers, self-funded employers and employer groups can limit their risk and save money by reducing the delivery of low-value care to their plan members. Administrators can do this by identifying and prioritizing high-value providers who are currently in network. In addition, they may consider expanding their network coverage to include high-value providers who are out of network. Once high-value providers are identified, they can implement what is known as tiering and steering techniques, which encourage plan members to utilize high-value providers who are less likely to provide low-value care. It allows for the cost savings of a narrow network while still giving plan members the flexibility to choose who they receive care from. A few examples of ways to incentivize members include eliminating copays when visiting certain provider tiers, providing a rebate to members who stay below a certain spending threshold, or compensating members through an alternative shared savings arrangement. If implemented effectively, the results can be financially beneficial for both plan members and the employer alike. While the two cases are different in many ways, they hinge on a common notion. Payers and employers that can accurately identify high-value providers will obtain substantial advantages. The savings generated can either improve profitability or be used to help gain competitive advantage in the marketplace. For example, health plans can afford to offer more attractive rates, and employers can win the loyalty of their employees through shared savings. This begs the multi-million-dollar question. How can your organization go about identifying high-value providers, especially when you have limited data on their historical performance? The short answer, it's extremely difficult. But Health Quorum has focused on this exact question for several years, and I'll provide a window into how we do it by leveraging historical CMS claims data, along with a collection of other data sources. Our first step is to identify all eligible providers in a given area being analyzed. It's important to only compare providers who are similar to one another because specialty, geography, and patient populations play a large role in the evaluation process. Step 2, you must create a means to screen for specific instances of patterns of low-value care. Health Quorum has developed an AI-powered low-value care detection engine that analyzes claims data and reports on any low-value care it finds at the individual provider level. Step 3, we incorporate the low-value care results into a scoring methodology, along with a number of other metrics that vary by specialty. Step 4, providers are risk-adjusted by applying HCC, or Hierarchical Condition Category Classification System, to our metrics. And finally, scores are generated for each provider in Step 5, allowing us to determine the highest value providers and the projected cost savings that can be achieved. Here's an example of a surgeon with no low-value care detected and how he can have an impact on your bottom line. As you can see, he receives a relatively large number of patient referrals at over 4,000 annually. We observe that he opts for less expensive procedures when appropriate, leading to a low ratio of expensive surgeries to referrals. We also screen for a myriad of other factors, including the cost effectiveness of his prescriptions and procedures. We adjust for relative sickness of the patients he has seen and compute a score based on how he compares to his peers. So clocking in at 4.64 out of 5, he is determined to be a high-value provider. We can demonstrate potential savings by comparing him to another surgeon nearby who has a score of 2.13 out of 5. Based on available data, we're able to project savings of 18% when the surgeon with a higher score is utilized. Actual dollar amounts will vary depending on a number of factors, but we've seen numerous cases where steering to one specialist over another can lead to 7-figure annual savings. Think about what 18% savings on even just a handful of providers would mean for your organization. Here you can see a brief screen capture of navigation within our flagship platform, HealthQuorum Now. Users can access the Create module, which would apply to the network expansion efforts we discussed in case 1. They can choose the Optimize module, which would apply to the tiering and steering efforts discussed in case number 2. And for evaluation by county and zip code, we come in by selecting the Evaluate module to drill down into the county of interest. Users can view analytics on different types of provider organizations, as well as several risk factors applicable to the selected county. If we click to view individual providers, you'll see that orthopedic surgery is already selected, and we can now view high-value providers at a granular level. Before moving to Q&A, we would like to officially announce the release of our new standalone application, HealthQuorum Live. As the name suggests, it allows for any organization to detect low-value care in real time as soon as your claims data is available to you. The application is deployed on the client side and brings with it the low-value care detection technology they've been focusing on since our inception. Not only does it allow you to identify room for improvement, but it can serve as a way to track your progress and quantify the reduction of low-value care delivery over time. We truly appreciate you being in the session today. For more information or to speak with us about either offering, please reach out at your convenience. Thank you for listening and submitting your questions, which I'll move to now in just a moment here.